Well, we have a serious paper to review now. It's Sunday, the 9th of February, despite what I might have said on the last video. Now, this paper is from the Journal of the American Medical Association, JAMA. Very prestigious journal. 7th of February 2020, so fairly hot off the press. And it's a retrospective. Now, retrospective means it's looking back. So there's two types of study. Prospective will be, I think I'll collect data from now up until next month. Prospective, or next year, whatever it is, that will be prospective. Retrospective is, can I collect data looking back? So it's retrospective, looking at the things that happened. And it's a single centre and it's a case series. So it's only a single centre. So that means it all comes from one place. It all comes from Wuhan, actually. Multi-centres are usually better, but this is a single centre one, so it is fine. It's published in JAMA. So, and it's a case series. It's a series of patients that they're reporting on. And they're reporting on 138 patients with NCIP, which stands for Novel Coronavirus Infected Pneumonia. So this is patients with pneumonia caused by the novel coronavirus of 2019. Now, I think the first thing to say is that this is a complication. This is a complication. So in a previous study we looked at from the Lancet, I think it was, the complication rate for this sort of complication, this patient's developing pneumonia, was about 17% of the people that got the virus, that were infected with the virus. Many others had a much milder form of the disease. In another paper we looked at things that carry risk for people getting more severe episodes of the disease. So if two people get infected, why is one person more likely to have a more serious illness than another person? And it came up with some things. It came up with the fact that, well, the correlation that people with hypertension seem to be more at risk, high blood pressure. Haven't quite worked that one out yet. It's interesting. I've got an idea I'm working on, but that's not for this video. And the other one was increasing age. And the other one was smokers. Even people that have stopped smoking were at increased risk of getting more serious disease. Now, a lot of papers are still talking about other comorbidities like diabetes, heart disease, COPD, lung disease, other long-term conditions, saying that these other comorbidities increase the risk. Now, that may well be true, but there's no particular evidence for it. And the other study we looked at a few days ago didn't show a risk. It just showed hypertension and smoking. Increasing age does seem to be a risk, though. The increased number in apparent cases in men in China may be related to the fact that more men than women in China smoke. So if you smoke, this is a good time to stop. It's always a good time to stop, but this is a particularly good time. And this data was collected retrospectively from the 1st of January to the 28th of January 2020. And the final data follow-up was the 3rd of February, just prior to publication on the 7th of February. And it's now the 9th. Now, the results. Median age, the age in the middle was 56 years, but the range was 22 to 92. So a wide variety of ages, but, you know, erring towards the more middle-aged, more elderly type of patient. And 54% were men. Actually, a smaller number of men suffering more severe complications than the other data. But as we've said, that might be related to the smoking. Now, the R0, the reproductive spread, the rate of spread, was calculated in this case at 2.2. So that means the R0 is on average, every infected person infected 2.2 other people, on average. It's only an average. But for example, this chap that went to Singapore and flew back and stayed with his British friends in a chalet in France infected at least 4 other people and maybe 5 other people. But 4 as far as we know. So That's just an average, is this figure given here. Now, remember we're talking about patients who've already got a complication here, patients with novel coronavirus infected pneumonia. So as we've said before, the pneumonia is infection at the level of the alveoli. So the bronchial passages divide down into the bronchial tree, trachea, right main bronchus, left main bronchus, into progressively smaller bronchial passages. 3 lobes in the right lung, 2 lobes in the left, and these subdivide into numerous smaller and smaller passages into the segments of the lung and smaller areas than that, lobes then segments, and eventually these end up in the alveoli. These these divide and they end up in a terminal bronchiole there. The terminal bronchiole will divide into respiratory bronchioles, and these actually have some alveoli in their walls. The respiratory bronchioles, first site at which gaseous exchange takes place, and then we have the large clusters of the alveoli. So bronchitis is infection at the level of the bronchial tree. At this level, that's bronchitis. Pneumonia is infection and inflammation at the level of the alveoli. And particularly what happens is inflammatory fluid collects in the alveoli. As we've looked at before on these videos, that means the oxygen can't get into the blood and the carbon dioxide can't get back. So that means that the carbon dioxide can build up, the oxygen can go down, the patient will become hypoxic. So these patients have got fluid in their lungs, and we can see this on the X-ray. There's consolidation. These are supposed to be hollow, they've become solid. So these are patients who've developed this complication as a result of novel coronavirus, and they have an infected pneumonia. And this is what a pneumonia is: the infection and inflammation at the level of the alveoli. Now, the patients with this nearly all had a fever, which is not surprising. As we've said before, fever is good because fever is a protective mechanism. The immune system works best at febrile temperatures, so fever is good. Now, a lot of people, as soon as patients develop any fever at all, rush to give antipyretic drugs, paracetamol, I think that's Tylenol in the States, acetaminophen, sorry, in the States. That brings the fever down. Patient feels better, the fever goes away, so they think you're clever. But actually what you're doing, in my view, is reducing the efficiency of the immune system. So fever is good. So 136 patients out of the 138. Remember the N here, the number, equals 138. 138 patients. 136 of those had fever. 98.6%. That's not a temperature, it's a percentage. They were nearly all fatigued. This seems to be a feature of this condition, undue tiredness. Most had a dry cough. Many also had achy muscles, though we're not given the figure. And some had, a lot, 70% had lymphopenia. Now, the lymphocytes are the white blood cells. The lymphocytes are the leukocytes, or white blood cells, that produce the antibodies. And the antibodies are the immune proteins. And it's these antibodies or immune proteins which fight the infection. And penia is a lack of. So part of this disease process is that it reduces the numbers of the very cells that are protecting the body against the infection, which of course is bad and concerning. Prolonged prothrombin time, it was up a bit. 80 had that, 58%. This is related to blood clotting, so the blood was clotting a little more slowly. I mean, in other viruses like Ebola, they're hemorrhagic illnesses, that the patients bleed all over. There's no suggestion of this in this group, thankfully. Elevated lactate dehydrogenase, which is often an enzyme that comes from the liver. So there may well have been some inflammation in the liver here. In 55 patients out of the 138. And when they took x-rays, lung computerized tomography, bilateral opacity in all patients. So the lungs became opaque in both sides. So bilateral means it's affecting both lungs. And the opacity is caused by the inflammatory fluid. So that means all these patients had X-ray features or CT features consistent with infected pneumonia. So that actually makes sense. Now, median time from first symptoms of the disease were 5 days. Median time from first symptoms to dyspnea. So I've used American spellings throughout here, by the way. We spell it differently in the UK. So the median time from people getting the first symptoms of the illness, from when they first realised they were sick. So if we use this graphic we've used before about the evolution of the condition. So here's when people start getting sick, this red line. So from when people first started feeling sick to when they developed shortness of breath was 5 days. So they were already into the illness phase when they developed shortness of breath. And the complications of this condition do seem to come on after some time. They develop. So the shortness of breath was 5 days. Time from onset of symptoms to hospital admission was 7 days. And time to acute respiratory distress syndrome, the ARDS, caused by this inflammatory fluid and the inflammation in the lungs, was 8 days. So it was the pneumonia, as far as I can see, that caused the acute respiratory distress syndrome. This ARDS can be caused by different things. It can be caused by inhaling inflammatory gases. It can be caused by trauma. In this case, it was caused by viral infection. Now, the most common symptoms at the onset of the illness. So these were the symptoms here at the onset of the novel coronavirus infected pneumonia. These features here. These were the clinical features when they just started to get symptoms of the novel coronavirus before they developed the complication of pneumonia. So these are presenting features. So these are features we could expect to see in people presenting with novel coronavirus infection. When they get these features, they may go on to develop complications. We think about 17% do. But many, of course, will just get a short-term illness, but still probably have similar features. So fever, they nearly all had fever. Virtually everyone had a fever. 136 out of 138 had fever. 98.6% had fever. Nearly 70% had this undue tiredness, this fatigue, which is characteristic. 82, that's 59.4%, had the dry cough, which again is characteristic. The achy muscles, which is also characteristic, affected 34.8%. And the shortness of breath at the time of diagnosis affected 31%. Now, what we believe here is that this dyspnea, this shortage of breath early on in the condition, is not caused by the pneumonia. That presented later. So if true, this can mean that people are short of breath who don't have the pneumonia, which in a sense is reassuring. Now, this was interesting. Diarrhea and nausea was the initial presenting feature, or very early on in the disease process, in 10% of patients. Now, this is new. And actually, in this case, people with diarrhea and nausea are actually admitted to another ward, I think a surgical ward, where they cross-infected some other patients, because we're assuming that the diarrhea and the vomit is infective. It has the virus in it, we are assuming. We know from the American case that the person definitely excreted the virus in his stool at some stage of the illness. So we know that the coronavirus lives in the gastrointestinal tract in animals. or some animals, and it appears it does in humans also. So the feces, the stool, and the urine of infected people must be considered to be infected. So when they go to the toilet and they flush the toilet, make sure they put the lid down first, so we don't get aerosolization of the virus from their feces into the air. And meticulous cleaning of the toilet with detergent would also be good, following the manufacturer's instructions, as we looked at yesterday on the bottle of detergent that you're using. So, interesting, diarrhea and nausea 1 to 2 days prior to the development of the fever and dyspnea. So, 1 in 10 people presented with gastrointestinal features. That's interesting. Less common: headache, dizziness, abdominal pain, diarrhea was 10%, as we've said. Nausea and vomiting in that 10%. So interesting information there about presenting features of the condition for new patients, people who are wondering if they have the disease, or doctors who are trying to diagnose the disease. Could take these factors into consideration when the doctor decides whether to send off samples for testing or not. That combined with the patient history, of course. Right. Treatments that these patients were given. Well, they were given antiviral therapies. Now, there is a trial going on in the States, not in the States, in China, about this, but at the moment these were just given because the doctors thought it might be a good thing to do. It's called compassionate prescribing. There's no evidence for it. Antibiotics were given. Now, antibiotics will not, absolutely not, kill the virus, but antibiotics will prevent the development of secondary infection. And if secondary infection is already present, it will treat that secondary bacterial infection. And we looked at the way that the virus can destroy body cells, the lining of the respiratory tract. And we looked at the way that infected cells can be destroyed by the body's immune system, by these natural killer cells, these T killer cells, the natural killers that just kill the whole cell in order to kill the viral particles in the cell. And that is going to damage the lining of the airways. It's going to damage it. And when it's damaged, that makes it easier for secondary opportunistic infection to get in. So giving antibiotics is actually quite reasonable. Now, some were given steroids, glucocorticoid therapy. I'm not in a position to comment on that. Some studies say it's a bad idea. I mean, the basic idea is that steroids, glucocorticoids are steroids. The idea is that they would reduce the inflammation, which is causing the acute respiratory distress syndrome. So they thought that they would reduce the inflammation, and if they reduce the inflammation, that will reduce the amount of fluid getting into the lungs. But the downside of that is that giving steroids reduces the immune response as well. So it's one for debate and one for future research. That now patients treated in the intensive care from this group. So of this group of 138. 36 were treated in intensive care. That's 26.1 of those that already had the complication of the infected pneumonia, the novel coronavirus infected pneumonia. ARDS, acute respiratory distress syndrome, affected 22 of the patients. Now, this is new as well. 44%. That's of these patients that were admitted to the intensive care unit. So, in other words, 16 of the original 138. 16 of the 36 that went into the ICU, who were 16 of the original 138, developed arrhythmias. Now, when the JAMA says arrhythmias, what they mean is dysrhythmias, that there were abnormal heart rhythms. So there was interference to the normal sinus rhythm of the heart in 16 of the 138 patients. 16 of that's 44.4% of the ones that required intensive care. So that's interesting. So the heart is being affected in some patients here. Shock affected 11%, as you might expect with a sepsis type scenario. And some had acute cardiac injury. Now, they didn't say how they knew this, but I'd imagine that they're measuring troponins in the blood. So the virus is damaging the heart to some extent in some patients. And acute kidney injury is reduced renal function, what we used to call acute renal failure, again in some patients. The patients admitted to ICU were older. Median age was 66 versus 51 in the other group. And remember, the overall age was 56. The patients admitted to intensive care were more likely to have comorbidities, that's other diseases. That's interesting data. Not just hypertension, but all other diseases they found they were more likely. More likely to have had shortness of breath, and more likely to have anorexia. Now, anorexia is not feeling hungry. So what this is saying is loss of appetite could be a possible risk factor for complications. Now, as of the 3rd of February, when this journal went to bed, when it was sent for printing, or into the computers these days, 47 had been discharged. So that's of the original 138. Now, 6 had died, giving a mortality of 4.3%, which is terrible. But remember, these were patients who already had been diagnosed with infected pneumonia. So these 138 were already in, we think, about 17% of patients who developed complications, who developed infective pneumonia. So 6 of the patients that developed this complication died. Remaining patients are still hospitalised. Among those discharged alive from hospitals, so the patients that were discharged alive from hospital, they tended to stay 17 to 14 days in hospital. And a big issue here was, again, we're talking about reasonably early in the epidemic, in January. 41 of the cases were thought to be associated with hospital-acquired or hospital-associated transmission. So we know that some patients caught it from the patients with presumed infected diarrhoea, but others caught it in the hospital. So these were a combination of staff and patients who were in the hospital, who then went on to develop this complication. So some interesting points there about the people who do suffer complications based on this publication in JAMA.